Okay, okay, welcome everybody. We very much appreciate you taking the time to join us this afternoon. My name is Jonathan Roop. I am the director of the Injury Prevention Research Center at Emory. It's my privilege to introduce this presentation on behalf of the Injury Prevention Research Center at Emory, as well as the Emory Office of Respect, which is jointly sponsoring this. So the topic of today's presentation is how COVID and the COVID-19 related movement restrictions that were designed to reduce disease transmission may have affected intimate partner violence. The topic itself is relevant and important. Today, our presenters will describe a mixed method study that will help to elucidate some of the underlying reasons that COVID-19 related movement restrictions may have affected IPV in a population of patients seeking care at the emergency room at Grady Memorial Hospital in Atlanta, Georgia. The project is led by a multidisciplinary research team, including Dr. Dabney Evans, Dr. Randi Smith, and a PhD candidate, Azade Tabaie. The presentation is going to be moderated by Dr. Sheryl Heron. And so we're very excited to have you here. Next slide. More. So, but before we get started, I do want to tell you a little bit about the Injury Prevention Research Center at Emory. IPRCE is a multidisciplinary injury control research center funded by the Centers for Disease Control. We focus on preventing the top 5 causes of injury death in the state of Georgia and the southeastern United States. These include overdose, falls, traumatic brain injury, violence, and transportation injury. We support 5 volunteer task forces. And if you're interested in learning more, I encourage you to visit our website at IPRCE.emory.edu. Similarly, if you're interested in learning more about the Emory Office of Respect, I encourage you to visit their website at respect.emory.edu. And so at this point, I'll turn it over to Dr. Dabney Evans to begin the presentation.
Happens at least once a day that I don't unmute myself. So this is the first time today. Thank you so much, Jonathan. And thank you so much to IPRCE and the Office of Respect for hosting this event, especially during this month of domestic violence awareness. We're really grateful to be here. I also want to start by acknowledging our other co-investigator, Dr. Amy Zaiden, who is on a much-deserved vacation this week. So she's with us here in spirit, and we hope we can represent her and her work as well during our presentation. As Jonathan mentioned, we have a multidisciplinary woman-led team that we're very proud of that span multiple units of the university and multiple departments, including the Rollins School of Public Health, the School of Medicine, the Department of Bioinformatics, Department of Emergency Medicine, and the Department of Surgery. So we're really grateful to be here today, and each of us will be speaking in turn. But just to set the stage a little bit, as we all know, we're living through this pandemic. But if you'll recall, a year and a half ago at the outset of the pandemic, there was a great call for looking at the potential for the ways in which movement restrictions that were really designed to protect public health, things like shelter-in-place orders and quarantine and isolation, these things which are public health measures that are very well justified in the context of a pandemic, but the ways in which those particular measures might be negatively influencing experiences of violence and abuse within relationships. We knew from some past emergencies, things like the Ebola virus disease pandemic, as well as Hurricane Katrina and other natural disasters, that violence does go up in these kinds of circumstances. But as a novel pandemic, a novel disease, COVID, we didn't know anything specifically about how COVID and these movement restrictions in particular were going to be affecting relationship violence. So that was really the thing that spurred our investigation. At the beginning of the pandemic, we did see some anecdotal evidence coming out relatively quickly from shelters and police departments. For example, in France, a 36% increase in IPV cases, and in China, a twofold increase in the month following movement restrictions. But again, these were anecdotal data, not necessarily systematically and scientifically collected. So this anecdotal evidence really prompted a call for investigation, systematic measurement and investigation into the effects of COVID-19, as well as movement-related restrictions on intimate partner violence. And so that was really the thing that we set out to do in this work. Before diving into our health data, though, we wanted to look at some data that were more readily available. And so we began by looking at data available from the Atlanta Police Department, because those data are gathered, and in the case of Atlanta, they're reported publicly, very close to real time. And as we know, there is a lag with health data. And so we wanted to do this first analysis looking at the factors that were taking place in real time. So what you see here on this slide in the graphic is the weeks of 2020. We specifically looked at the first 31 weeks of 2020, overlaid with some of the major events that were taking place during the pandemic. So for example, you see the start of the declaration of a public health emergency of international concern on the global stage, followed shortly thereafter by the first case in Georgia when the state of emergency was declared in the state. And then when city of Atlanta and statewide shelter in place orders, as well as when those things were lifted. And also important to recognize some of the civil unrest that was taking place during this time that also related to widespread media reports of increases in crime. We think that's an important factor to look at. And I'll talk about the way that we saw those things interacting. But up above here, what was happening in the state before COVID or before shelter in place, during that time period, and then after the shelter in place had been lifted. So we wanted to look at differences at domestic violence reporting from, again, police department data within the first 30 weeks of 2020. And we compared those to the two prior years, 2018 and 2020, to see what the differences were. And so what you see, again, thinking about the weeks of the year, is you see in the first couple of weeks, and everyone will remember that week in March when things really sort of came to a head, that there was even overlap between the prior year and 2020. But then we see a sudden spike taking place around week 15, and that coincides directly with the statewide shelter in place orders. And we see the 2020 year, the reported domestic violence crimes going up and up, climbing steadily with each week until the statewide shelter in place order is lifted around week 18. We again see another rise or another separation from the prior years. And this corresponds with both the summer spike in COVID cases, as well as the fallout from the murder of Rayshard Brooks, which of course took place here in Atlanta. And we looked at this not only with domestic violence data, but also other crime data. And I think it's really important to say that while there were widespread media reports of increases in crime, we did not find that to be true. However, there were increases in domestic violence related crimes. So overall, we found an 11% increase in domestic violence crimes relative to the prior 2 years. So that really gave us some data to start with from the police department. And then we wanted to turn and look to a different setting, which was the hospital-based setting. And so that leads me to the study we'll be talking about today, which is the effect of movement-related restrictions on intimate partner violence in Atlanta as a result of intimate partner violence. And we had 3 aims to this study. So the first was to determine the incidence of traumatic injury, specifically intimate partner violence, during the pandemic, defined as February to August 2020, although we know that it's ongoing, as compared to the incidence in the prior year, using a process called natural language processing, or a technique called natural language processing. Second, we wanted to identify contextual factors related to the hospitalization and traumatic injury during the COVID pandemic through a detailed chart review, and Randi will talk about the slightly different time period for this aim. And then we also wanted to describe the effects of COVID-19 related movement restrictions on trauma and IPV, including health-seeking behaviors through qualitative interviews with intimate partner violence survivors and healthcare providers. So I'll turn it now to Azade to talk about AIM-1.
Thank you, Dabney. So in AIM-1, we wanted to come up with an algorithm based on natural language processing that is capable of identifying cases of IPV among the visits to emergency department. For training such a model, we extracted unstructured data from electronic health record, such as clinical provider, nursing and social worker notes, along with chief complaints. We extracted this information for all the encounters starting 2012 until August 2020. We also extracted ICD codes because we wanted to have a baseline model to be able to compare the performance of our proposed NLP model to our baseline model. So for our baseline model, we look at the ICD codes assigned to each visit. If any of those ICD codes indicates IPV or domestic violence, we classify as that visit as being IPV, otherwise non-IPV. But since the IPV visits are highly undercoded, using this baseline model didn't significantly help with identifying IPV cases. So moving on with our NLP algorithm that we proposed, we had two sets of situational terms defined. First one is 23 situational terms derived from existing IPV literature. Terms such as intimate partner violence, spouse abuse, referral to partnership against domestic violence. If any of these terms appeared in any of those recorded notes from the providers or patient narratives, then we classified that visit as being IPV, otherwise non-IPV. Then to add more strength to our model and expand our search and identify more cases of IPV and don't miss the rest of them, we added 49 extended IPV situational terms, which are basically mechanism-related terminologies and are the specific descriptions of various forms of physical abuse, such as attack by significant other, strangled by X. And now that we have the terms that we need to look for in the clinical notes, the recorded notes, we need to pre-process our notes to make the text consistent and make it ready for the detection process. Advance. First thing that we do is to apply general text pre-processing techniques. These are basically transforming the text to lowercase, removing time indications, prepositions, numbers, dates, and extra white space, and then try to make the tense of the words consistent, tense of the verbs, sorry. For example, on the top left, you can see medical social worker met with patient at bedside to address any concerns. Patient admitted she was physically assaulted by her ex and the father of her children. On the right-hand side, you can see that all the text is lowercase, and then we have assaulted by her ex highlighted here. To be able to capture these notes as being IPV, we remove the ED at the end of the verb assaulted, and then also the preposition her. And we ended up having assault by X, which is among the terms that we predefined as being IPV related terms. So this visit is gonna be classified as being an IPV related visit. The other challenge is that there are many screening questions that are asked from the patient, and the questions themselves include IPV terms. For example, are you experiencing domestic violence? Are you experiencing intimate partner violence? If we don't exclude those questions from our analysis, we're gonna have many, many false positives. So we exclude the screening questions regardless of them being answered or left blank. The next challenge is negation and history detections. For example, there are patients who say, I had a history of IPV 5 years ago. It's not associated with the reason for the current visit. So it's a historical thing that the patient mentioned. or the patient may deny having experiencing domestic violence or intimate partner violence. So this is a negation that we need to detect. Otherwise, it's going to produce, again, false positives. So if we look at the lower left box here, patient has a history of IPV 5 years ago. She denies domestic violence. The patient feels safe at home. So if we look at this note, we note that it's not associated with an IPV visit. But if we apply our algorithm, the detection algorithm on this, it's going to say there is IPV and there is domestic violence. So it's an IPV visit. To basically deal with that problem, we defined a set of history terms and a set of negation terms, plus a set of termination tokens. For example, here we have history of as one of our historical tokens, history identification tokens, and then period as the termination token. Anything between these two is gonna have underlying underlying history at the end, so that it won't be count across being like an IPV term. The same thing for negations. Denies is among the negated negation terms, and then we have, again, period as a termination token. Anything in between will be negated, so that our algorithm won't pick that up and won't generate false positives. Then the rest of the text would stay the same. The patient feels safe at home. Advance. Using this algorithm, we wanted to compare the rate of IPV visits in February to August 2019, which accounts for our pre-COVID period, and February to August 2020, which accounts for the pandemic period. So the rate of IPV visit was higher in 2020 with 0.82% compared to 2019, which was 0.72%. If we define the new IPV encounters as being the ones who didn't have any prior hospital visits for IPV-related reasons, then this rate was also higher in 2020, which was 0.59% compared to 0.25%. Our analysis didn't reveal any statistically significant difference in age, death rate, or length of stay. So this was the result for AIM 1, and now I'll hand it over to Randi. Thank you.
Excellent, Azade. I'm just so impressed that you're able to condense several months of blood, sweat, and tears down into this amazing talk. Thank you guys again, IPRCE and the Office of Respect, for the opportunity to present our work. Once again, my name is Randi Smith. I'm a trauma surgeon here at Emory University and Grady Memorial Hospital, and I spearheaded AIM 2. So for this AIM, we sought to identify contextual factors related to the hospitalization of traumatic injury and IPV during the COVID-19 pandemic. To achieve this, we conducted an interrupted time series analysis for violent injuries between January of 2016 and August of 2020 at Grady Memorial Hospital. An interrupted time series analysis is a quasi-experimental design involving tracking a long-term period before and after an event or start of an intervention to assess the effect of that event or intervention. So for this project, our interruption variable of interest was an event. It was a movement restrictions in Atlanta, also known as the lockdown, that happened the week of March 16, 2020. And we purposefully included several years before COVID, as Dr. Evans mentioned, to make sure that we had an accurate account of our baseline rates, as accurate a baseline rate as possible. If we were only to use a few months before, or even a year before the start of the lockdown, there's concern that there may be seasonal variability or other confounders that may skew our data. So we extended our time frame to be about 5 years. Next slide. So to define our cohort, we started with IPV cases that were identified in EPIC, the electronic medical record system at Grady, using our novel NLP algorithm that Azade mentioned. We then triangulated our data with trauma registry data. Next slide. During our study period, there were 4,624 IPV cases identified in EPIC. 292 of them were found in the trauma registry, so that was about 6.3%. For most of the talk, when I refer to IPV cases, I'll be using 292 as my sample size. I do want to note that we did do some subgroup analyses, which I'll briefly discuss at the end of my section. Next slide. A quick word about the trauma registry. So the trauma registry is our institutional trauma database that includes individuals admitted to the hospital for 24 hours or longer. It doesn't include individuals who are seen and immediately discharged from the emergency department. So for example, if someone comes in with a gunshot wound, it turns out to be more of a grazed wound, it doesn't cause a fractured bone or it doesn't injure any blood vessels or soft tissues, then those patients may be seen by an emergency medicine provider and discharged home within a few hours. They will not be captured in our trauma registry. The only caveat is that individuals who come into our trauma center and are pronounced dead upon arrival, unfortunately, they are captured. So as a result, this is a good estimate of high acuity IPV cases, those that require hospitalization, but it definitely does not tell the entire story of IPV, and it's a tremendous gross underestimate of our overall IPV incidence. So we're looking at a specific population, hospitalized IPV victims. Next slide. Similar to the police data that Dabney presented, we did an interrupted time series analysis of all violent injuries, which were included gunshot wounds, stab wounds, and blunt assaults. And we looked again from 2016 to 2020. For this study, we looked at COVID lockdown as the week of March 16, 2020, and the killing of George Floyd, May 25th, 2020, as our interruption variables of interest. Anecdotally, during that time, we were experiencing what felt to be significant shifts in volume related to the death of George Floyd and the subsequent protests and social justice movement. So that's why we added it as another variable of interest. We assessed temporal associations between the interruption events and incidents of violent injuries using Poisson regression. And we found that there were a total of 5,811 violent injuries during this time frame. In the weeks prior to the killing of George Floyd, I'm gonna start with the George Floyd event first, but in the weeks prior to the killing of George Floyd, there was a mean of 22 violent injuries per week. However, in the 23 weeks afterwards, there was an increase, a mean of 33.2. So the incidence rate ratio was 1.4, meaning that there was a 40% increase in total violent injuries after George Floyd's killing, which is illustrated with that steep increase in the slope of the red fitted value line that you see here. And interestingly, looking at the lockdown from COVID and movement restrictions, that was not associated with a change in baseline incident rates for our total violent injuries. However, not pictured here, but when we stratified by IPV, so going back to that 292 sample size, we actually did see an increase in IPV after COVID lockdown from our baseline that was statistically significant. There was about a 17% increase in IPV per week following the COVID lockdown. Next slide. So looking at our demographics of IPV cases specifically, our median age was 38 years. Next slide. The percentage of males in our cohort was 27.4%. 27.4%. This is interesting because national averages of male IPV range from about 10 to 11.5%, according to the CDC. So our cohort is approximately 2.5 times higher than national averages. Most individuals were Black and most suffered from blunt mechanisms. And I'll expand upon the different mechanisms of injury in the next slide. One metric that we use to determine severity of injury is called the injury severity score. A score of 15 or higher is usually the cutoff that's talked about in the literature that denotes severe injury. And our total cohort had a mean ISS of a little over 9. Next slide. Here's a chart of the mechanisms of injury. And as you can see, disturbingly, there are several different ways that our patients are injured by IPV, including gunshot wounds, stabbings, chokings, being pushed down or assaulted with punches and kicks or with other objects. Next slide. We looked at demographics pre-COVID versus post-COVID and other clinical characteristics. When we looked at this, the only thing that we found that was significant was that younger age was associated with IPV after the COVID lockdown. You can advance the slide, I think I have, yes. Before COVID, the average age was 39 years old, but during COVID, the average age dropped to 34 years old roughly, and that had a p-value of 0.04. GCS stands for Glasgow Coma Scale. It's a marker of mental status and level of alertness. And these are some clinical characteristics, but GCS, injury severity score, ICU days, etc., were similar between the two groups. The number of total days in the hospital approached significance. That p-value was 0.05, as you can see. Patients were in the hospital fewer days during the COVID pandemic, which I think is likely a function of our overburdened system during the time and a push to expedite safe discharges to overcome limited resources. Next slide. We also looked at gender differences between the group. Since we had such a high percentage of male IPV, I wanted to do a deeper dive. Remember that we were 2.5 times that of national averages. And what we found was that males tended to be older, next slide, and more critically ill, next slide, than their female counterparts. So it's interesting that there was not a difference in injury severity score between the two groups. However, males spent more time in the intensive care unit. And I think we probably need to do a deeper dive here and kind of flesh out why that is. Next slide. So we're not fully done yet with this aim. We're performing some subgroup analysis that I alluded to earlier in the talk. Particularly, I'm partnering with Dr. Dina Amin, an oral maxillofacial surgeon here, to look specifically at individuals with head and neck injuries. We're specifically interested in head and neck injuries because they oftentimes leave scars and can be associated with tremendous emotional and psychological consequences. I'm also partnering with Dr. Hernandez Irizarry and my ortho trauma colleagues to look at IPV and orthopedic injuries. We're also going to continue to collect data. We want to see if our trends return to baseline or if, unfortunately, this increase in IPV has become our new baseline. So there will be more to come. And we recently submitted a couple of abstracts from this aim alone and just welcome the opportunity to disseminate our results in national forums. So stay tuned for publications. And next slide. I think that's it for me now. I will turn it over to Dabney Evans to discuss aim 3, and I'm happy to answer any questions at the end of our collective talk. Thank you so much.
Thanks, Randi. So as I mentioned at the outset, we had these 3 aims, and the third aim was the qualitative aim that included interviews with both healthcare providers at Grady as well as survivors of intimate partner violence. So I wanted to share just a little bit of results from our interviews with healthcare providers. Those data collection have concluded. We interviewed 12 healthcare providers who included emergency room physicians, advanced practice providers, trauma surgeons, and social workers. And we had 3 themes emerge from these data. The first, very much in keeping with the quantitative data, was that COVID-19 movement-related restrictions likely exacerbated IPV. And that did pan out, as you saw in our quantitative data, both from aim 1 and aim 2. And I won't read the quotes to you, you all can do that. But these were just the things that providers themselves were perceiving as they were going through the pandemic and providing care to survivors. Healthcare providers encountered many practice and community-oriented barriers in IPV care provision during COVID-19. There was a major shelter in Atlanta that closed down. There were many seemingly ever-changing protocols for referral and admission, including COVID testing, and being able to safely discharge patients who had experienced IPV was really, really challenging during this time period. And then healthcare providers also had some concrete suggestions for how to improve partnership and how to think about preparedness in the future. And so these were just some of the takeaways. I'll share them briefly and we can go into them further in the discussion if folks have questions. The other thing I'll mention is that we have done some interviews with survivors and we're continuing to recruit survivors for this part of the study. So far, we've concluded 10 interviews. 5 of those were hospital-based, people who were patients at Grady, and 5 were community-based survivors. Of those 10 folks, 8 identified as cisgender, as being cisgender and in heterosexual relationships, and 9 of the 10 participants identified as Black. We have a couple of early themes that are emerging from these data. The first is that there were 2 relationship types that appeared in the data. First, relationships that formed shortly before or during the pandemic. And I think that that aligns nicely with what Randi shared about younger people during the pandemic. So as we know, there's a lot of insecurity, there's a lot of uncertainty as the pandemic was starting. And so it really seems that the pandemic acted as a catalyst to sort of bring people together looking for some sort of security in the form of a relationship. And then, of course, there were also relationships that existed prior to the pandemic. All of these relationships so far in our sample have been greater than 5 years, and all of those longer standing relationships also included prior experiences of IPV before the pandemic. So what did the pandemic do then to these both new relationships and ongoing relationships? For new relationships, COVID seemed to hasten the relationship trajectory. That is, moving the relationship along faster, people deciding to move in together. We all know that there were many social conditions that were changing, increased unemployment, a lot of housing insecurity, food insecurity. And these conditions, may have contributed to people getting into relationships and those relationships moving along more quickly, and the potential for, as Azade shared, new violence among people that had not previously experienced violence within the current relationship or prior relationships. In these new relationships, we also saw exacerbated substance use or prior substance use that was exacerbated among one or both partners in the relationship. For chronic relationships, things seem to look a little bit different. So those pandemic-related stressors still came up in the relationship, things related to finances, childcare, and household duties. But these are longer standing relationships, and the pandemic may really have exacerbated, concepts about gender roles and gender norms. Who's responsible, for example, for taking care of children during the day while they're home from school or being schooled virtually? Who's responsible for managing household duties and so on, in addition to working as many people were doing. And so these more rigid gender norms seem to contribute to more frequent and more severe episodes of violence, even among people that had been experiencing violence within their relationships before. So as I mentioned, this is a very small sample so far, only 10 interviews. We're hoping to recruit additional participants, and we've expanded our recruitment strategy to include social media advertising and flyers. And we have had some good responses for that, but we are still looking to recruit more folks so we can get some more information. So as I mentioned at the output, there was this speculation at the outset of the pandemic that movement-related restrictions and COVID conditions may have exacerbated relationship violence. And we found this to be true in our study. The UN has subsequently called this the shadow pandemic, or the pandemic within the pandemic. And our data support that assertion. But we also know that the pandemic isn't over. We looked at a short window of time at the beginning of the pandemic. And as most of us know, movement restrictions aren't in place, particularly in Georgia anymore, and they're not in place in many places at this point in time. Yet, as Randi said, there's potentially a new norm for what IPV is happening within our community. And so we need to continue to systematically measure and also look at how IPV is being affected both in healthcare settings and community settings to ensure appropriate responses. We found that, and we know everyone knows that the healthcare system was under tremendous strain during the pandemic, and particularly when COVID cases were extremely high. And healthcare providers may need some specialized training or additional support and resources for case management. One of the things that happened on the ground during this time period of really high strain, as we were all trying to flatten the curve, was that some of the universal screening measures for intimate partner violence were no longer being implemented. Those basic questions about, do you feel safe in your home? So we have the adage in public health, if you don't write it down, it didn't happen. And this really speaks to the importance of continuing those routine processes and monitoring even in moments of crisis. And not only that, but as we think about the pandemic continuing, thinking about preparedness, right? So this pandemic is ongoing. And there were certainly moments of crisis where we needed to be able to scale up support, but we also need to do a better job of preparing for pandemics and other public health emergencies and natural disasters, where there does seem to be this trend that intimate partner violence goes up during these times. So how can we do better in terms of having a baseline set of resources in place in our community that can also be scaled up during times of crises? So we'll stop there and then happy to take questions. Oh, and actually, before we stop there, I do want to make sure that we acknowledge there are many, many people that have contributed to the success of this project. So I just want to make sure that they're mentioned there and you see their names. We've had many folks, again, from across units of the university and across departments. Many students have been involved in this work, as well as community partners and IPRCE. This work has been funded by the Woodruff Health Sciences Center, and we're extremely grateful for all of this support from all of these folks. So thank you so much for that.
Thank you, Dabney. Incredibly rich work. Also, thank you to you, Randi and Azade, to IPRCE, as well as the RESPECT program for something that's really near and dear to my heart as well. My name is Sheryl Heron. I will serve as your moderator for the next few minutes. I co-chair the Violence Prevention Task Force of IPRCE, along with Lauren Hudak, who brings greetings, as well as Ursula Kelly, who's also here joining us, along with many of you who are members of our task force, so we thank you. As a Black woman also who works in the emergency department, it is incumbent on us to also thank our patients and remember them during these very difficult times. As you looked at the data, looking at the health inequities, as we heard so eloquently stated by Dr. Randi Smith. And so I encourage you to also use the chat, but please also raise your hand if you want to ask a specific question. But I will acknowledge and go to the chat first. And thank you for those who were willing to ask questions. But I will go with Sang-Mi Kim's question first. And it really speaks to, I would offer, Azade. And the question is really, how did you come up with the situational terms? And I guess it goes along with the question of the new method of the natural language processing that you used to measure IPV during this pandemic. And so can you talk a little bit about how you came up with those terms and really what's new and or different about this approach compared to what has been used in the past? Azade?
Sure. So the IPV situational terms were basically extracted from the existing literature in IPV domain. And we added the extended situational terms, which were the terms that we gathered through our manual chart reviews, and then looking through the confirmed IPV cases. So there were some terms that could complete our list, so we added them, and we called them extended IPV situational terms. And for the your following question, Sheryl, I think the difference between our methods with other methods in this field in detecting IPV cases is that we used unstructured EHR data, basically free text format of the data from the recorded notes during the visits of the patients. These notes are very messy. They're not easy to work with. They're very super complicated, but they are a very rich source of information if we want to know the details of the reasons for the visit and how things are going during the visit. So I would say one of our main contributions in this NLP approach is that we use the unstructured data. And I know that there are other studies in detecting IPV cases in which the researchers are using the assigned ICD codes. But these IPV visits are highly undercoded, and sometimes using only and relying only on the ICD codes may not be sufficient to identify these cases.
Yeah, thank you very much for your response, and also to you, Dabney, for responding specifically to Sang-Mi. So if you aren't able to monitor the chat, Dabney did speak to how the terms were sort of brought in from multiple screening tools that are out there to come to that conclusion. So with hopes that answers, that question. And as we think about, how do we collect data and how do we map things, I do want to acknowledge Rana's comment in the chat, which has been answered, that talked about comparing Grady trauma data to the Georgia Central Trauma Registry, because I think the ability to link those two would certainly bring more depth and breadth to the data that's being collected, and perhaps synergy or uncover things that might be missing. So thank you, Rana, for that statement, as well as to the responses that were there. There's another question or comment by Manderly Recinos, if I'm saying your name correctly, that really states, or perhaps asks, the question that it would be interesting to examine the rates of IPV during the pandemic for essential workers as compared to individuals who worked from home. I think there was a nod to some of the stressors in the latter aims that speaks a bit to that. But the question really, or statement, she states, is that IPV could have been influenced by stressors, which was, I think, alluded to, such as job loss. So it'd be great to examine rates of IPV for those who lost jobs and those who did not. And so either Randi or Dabney, your reflections or thoughts on that statement, please.
So I'll just say that we are collecting some additional demographic information from the qualitative participants, and the qualitative participants are drawn from the subset of the sample that was derived from the natural language processing, and also that Randi used in AIM-2. And so we do have overlap between those groups, and we are going to be asking some additional questions. But again, our qualitative subsample is much, much smaller. I agree that that would be interesting, and maybe there is potential for that. The challenge is that we really only have, in the original data set, sort of the information that's available in the electronic medical record, which may or may not include profession. But I'll let Randi add more if she cares to.
Yeah, no, I agree. I think that it would be really nice if we had all of that data at our fingertips. I don't know that we do the way that it stands now, which makes me feel like we need to do some type of cross-sectional study and ask these questions about jobs, whether or not the job was lost during the pandemic, whether or not they had to go into work, if they were an essential worker or not, because I do think that the stressors would be different between the different cohorts. It'll just be a very interesting take on this topic, and we would be innovative in the way that we address the question. I think we would have to be innovative.
Yeah, and I agree. Just to add a little bit more, more about some of the domains that we're exploring in the qualitative interviews with survivors is exactly what those stressors were for them. So really digging into, what do they perceive as contributing to their experiences of violence? Was it a loss of employment? Was it financial constraints? Was it being trapped at home, with their partner, not being able to leave the home or move freely? There has been a lot of concern and sort of speculation about the very well-intentioned public health measures of isolation and quarantine actually being used for perpetrators' benefit, as a form of coercive control and controlling behaviors. And so that's what we hope to dive into with the survivor interviews. We are getting some of that already.
One of the other pieces to the second specific aim that we're diving into is looking specifically at community level socioeconomic factors. So looking at a metric called the Distressed Communities Index, which uses census tract data to look at several markers. Of course, there's always a little bit of a lag, but looking at median household income, unemployment, and homelessness in a certain community, and seeing if there are different areas around Atlanta that experience IPV at a different rate than others. I have been working with Dr. Sewell from the sociology department, looking at different contextual factors like that. And it's something that I hope that we can continue to do with this project as well.
Thank you, Randi. Nicole, I see your hand raised. If I can call you Nicole, please go ahead.
You can, that's totally fine. I was curious about, I know that one of the challenges with like kids not returning to school was that kids just weren't being seen by other trusted adults. Did y'all find that either that was the case, or that you were seeing maybe more disclosure or more free disclosure of details and things like that when you were interacting with participants who are facing intimate partner violence? I can explain more. I hope that question makes sense.
So I can share from the qualitative data that we have had people talking about, things that we're specific asking people, what were the circumstances that brought you to seek care? And healthcare seeking was one of the things that we really wanted to examine, whether that care was in the hospital setting or whether it was in community-based support. And one of the things that we are seeing is that intimate partner violence was one of those reasons, but as was other concerns about things that were happening in the household, including fights or disagreements and arguments with children, or potentially even child abuse. But you're exactly right, Nikki, that the largest reporters of child abuse cases are teachers who, in great part in the last year and a half, haven't seen students except for the same little square that we're all looking at. So there's a lot that we're missing. And so I think you're right that there is a lot to be explored, and we are seeing that within the qualitative data. I don't know that we have that, we only looked at adults in our sample, and so we did not look at child abuse specifically. We were looking at intimate partner violence. So in our original sampling for the natural language processing, we weren't really looking for that, but I certainly think there's work there that could be done.
Thank you, Dabney. I really appreciate that, and to you, Nikki, for the question. In the chat, there's a question that comes up to you, Randi, that it relates to what kind of preparations would be needed to look at IPV cases that aren't in the trauma registry. How are these individuals screened? The same way hospital patients are. It does speak to the complexity of how data is collected, whether it's the EMR, the Grady Trauma Registry, as it relates to these traumatic injuries. So how do we, circumvent that and given these challenging processes to improve the system for better data analysis?
Right. Well, before I start, I do want to say thank you to the trauma registry team. They extract a lot of data and they try to keep up with it, so we're not that far behind. And I know specifically Elizabeth Mace gets a lot of requests, and she's been awesome. I see her on the call as well. I wish that we actually had a magic way of identifying IPV cases that was as easy as screening and that it was accurate. One of the things that I didn't present was that a lot of our male IPV cases actually were picked up by our natural language processing algorithm and not by our screeners. They were not saying that they were victims. It was coming out later in their hospital course. So what that means is that, we need to make sure, number one, that we are doing universal screening even when our system is overburdened, because we don't want to miss cases during this high stress time, but that we have a good screener that is actually picking up on cases and find a way to make sure that people feel comfortable appropriately disclosing if they're in trouble. We ended up having to do something that was very innovative. We ended up coalescing two data sources. We used the EPIC medical record and then pared it down using our trauma registry. And I'll just mention that our trauma registry actually does not capture IPV at this time. I'm hoping that that's something that we can change. But when you do that, you assume all of the inherent biases of every single database, right? So every database has its own challenges, its own limitations. And so, when you coalesce the data, even though it's stronger because there's two data sources, you also have the inherent biases of both of them. And so we try to overcome this. Do we think that this is telling the whole story of IPV? No, but does it tell the story of those who are hospitalized and the high acuity? Yes. I think the way that we start, though, is by bringing awareness to this situation, making sure that we do continue to do universal screening as best we can, make people feel safe, like it's a safe space to disclose when they're in trouble so we can pick it up. And then once we identify IPV cases, having a game plan for allocating resources to individuals who need them.
No, thanks, Randy. And Ursula makes a good point that people may not understand, particularly what the Grady Trauma Registry is. So in just a minute, could you just give a quick soundbite on what that is and what that entails?
Absolutely. So the Grady Trauma Registry is our institutional database that captures all trauma patients that come in and are hospitalized for 24 hours or longer. As I mentioned, if someone comes in and they may have a traumatic injury, but they're seen and discharged from the emergency department, they would not be captured in our data set. So by default, it's an underestimate of our trauma incidence. The Trauma Registry is in place for a couple of reasons. Number one, we report all of our traumas to our governing body, which is the American College of Surgeons, but it's a way for us to keep track of how we do, our outcomes, a way for us to have quality improvement initiatives, and for us to make sure that patients are getting taken care of as best as possible for their traumatic issues. So we are a level 1 trauma center, meaning that we have the ability to take care of the highest acuity trauma patients. And one of the things that we have to do is keep track and record of all the work that we do with our patients. I hope that answered the question.
Yeah. You know, I think we all, I do the same thing. We think, oh yeah, Grady Trauma Registry, it's good to step back and give some insight. I know we're running short on time, but I do want to really acknowledge the question that was posed by Jennifer Thomas, also a friend, that talked about 20% of victims were male, and did we take a look at the gender of the perpetrator? It's absolutely important when you think about inequities across all the work that we do. We've heard about the racial/cultural inequities in terms of the numbers of Black people who are impacted more in terms of IPV. And we know that the social determinants of health, also known as racism, impact our communities of color around education, housing, et cetera. So, how do we begin to address these injustices and inequities in this space, knowing that IPRCE, we have put a stake in the sand to really pay attention to this issue and prioritize it? And then going back to Jennifer's question, how do we, and did we look at the gender of the male that stated we had such a high uptick? Was this a same-sex perpetrator? What was really happening there? I know it's sort of a two-part question, but definitely wanted to get that in there.
I'll start, and then I'll pass it to Dabney to maybe talk about the qualitative piece. But I'll tell you that when I'm looking through the charts of our male, or all of our IPV patients, I don't think that perpetration is always placed in the chart. I think a lot of times the provider is taking care of the patient in front of them, and they are very hyper-focused on the patient and not necessarily the context of the injuries. And so I do think that that's a limitation of our documentation. It's not easy to define who the perpetrator was. It may say an X, but we don't know the gender of the X. Sometimes we have that information if people use words like wife or husband, boyfriend or girlfriend, but a lot of times we don't have that information. It's a huge gap. The other thing, and this is something that our entire team has talked about, is the binary gender use in general. There are a lot of ways that people define their gender, and it's a limitation of our data sets because we really have put them into two boxes, male or female, and that might not be the way that they want to define gender for themselves. So moving forward, it would be really nice if we can be more inclusive. And if there were a way for us to have more information on the perpetrators, I do think that we can have better targeted interventions to prevent IPV in general.
I completely agree with everything that Randi just said. And yes, our team has talked about this in great detail. Within the medical record, as Randi mentioned, there may or may not be information about the perpetrator, but that's really mainly coming from like the medical notes or the social worker notes, as she mentioned, but that's not necessarily always present. There is sometimes information, more oftentimes information within the police records. So for example, I mentioned the Atlanta Police Department. There is information on perpetrators within those data, but all of those data, and as well, you can find that kind of information within things like the violent death reporting system, both at the national and the Georgia level, which Rana could speak to. And so you can find information about perpetrators, but I think that sometimes that information, specifically in the case of gender, that can be a little bit misleading because of the gender binary and because people can be in different kind of gender dyads, both male, female, as well as same sex and other, gender non-binary dyads or relationship formations. And so that is something that we really need to think about at the systemic or structural level. So just tying back to what Sheryl said, I think that we have to always bear in mind, I can't get through a webinar without talking about systems of oppression and talking about, patriarchy and the way in which that affects all genders, and talking about racism and the way that that affects people of all races, and the way that that shows up in relationships, sort of independent of how people identify. So we need to be able to look at data with these sort of categories that we've created, which are social constructs, right? Because race and gender are both social constructs, and the systems of power and oppression that have created those categories come into how violence manifests within relationships, particularly, and as if we're thinking about gender and partner violence.
Thank you, Dabney. I appreciate that, and to all of you. And so, I do want to acknowledge, members of our Injury Prevention Research Center Steering Committee, Executive Committee, who is on the call, including Lisa Dawson, who leads our Public Health Division for Injury Prevention. Certainly want to acknowledge, I saw that Dr. Sewell is here as well, who works with us tirelessly in our sociological sphere to keep us honest and true to the game. And certainly David Wright, who's our chair of our Department of Emergency Medicine. And most importantly, all 84, almost 90 of you who took the time, out of your schedules to participate. And, true to form, I like to end my meetings a few minutes early because we all run to the next meeting without eating or perhaps going to the bathroom. But before I do that, I will just take that last minute, if we could, for a moment of silence and reflection for those who have lost lives for intimate partner violence, for COVID-19, for all of you of the stress and the trauma that we have incurred in this space, and the willingness and the perseverance to continue forward. So please, let's just take a moment of reflection. Thank you, and have a good afternoon.
Thank you all. We encourage you to please visit our website at iprice.emory.edu to find out more about our educational webinars that we have offered. And again, thank you to the Office of Respect and our presenters today and moderator. I hope you all have a wonderful day.
Namaste.
Thank you.